All right, good morning. Today we'll be talking about Zygopophyseal joint dysfunctions, certain problems that present with it. Take you through some exercises, interventions. The objectives here, students will be able to understand the elements and phases of the rehabilitation process for this type of injury. Problem one, we have limitation of bending forward. So in our max protection phase intervention, we would do education and safety. So here we just talk to the patients about their posture, not overly extending, and when they're just sitting, not overly flexing. Just some good posture to protect the facets. We will also provide some tactile cueing, so I will show an example of that. And prevent joint atrophy and stiffness. And then for the mild protection phase intervention, we have supine knee to chest, scapular retraction for postural training, resistant band rolls. And then for the minimal protection phase, we have patients will return to function, single leg balance, medicine ball rotation, rotational throws, Romanian deadlifts. Now we will go into exemplifying some of these exercises. So for the tactile cueing, I want to show how that would look, so just good if you could. So your patient may come into the clinic presenting with excessive flexion. A good tactile cue. Just show the patient how to straighten up a little bit. As simple as that. Or if they're overly extended, another tactile cue. Step them. Flex a little bit. We'll do some scapular retraction education. That's just to help with posture if they're overly flexed. Helping them strengthen the muscles here. So I would tell them, squeeze into my hand. Squeeze my fingers. Hold that for about 3 seconds. Good. Also, I'll show you the Romanian deadlifts. So I have my patient here, dumbbells, slight bend, and I would tell them to pretend as if I'm pulling a string from their bottom, and they only go down as their bottom goes out. And so. Now if we have restriction with difficulty turning the head side to side or up and down, so we have the max protection phase interventions, education and safety, ice or heat therapy, some passive range of motion. We have the mild protection phase, joint mobilizations, down glide or up glides, upper trapezius and levator scapular stretch, isometric holds in each direction. For the mid protection phase, we have patients return to function, quadruped, chin tucks, resisted neck rotation, flexion and extension, and side planks. So for this, we're gonna go to the down glides and up glides. It's a good mobilization technique. Also, it's good to assess the patient. So here, I'm just assessing her down glides, seeing how things move. And then I will perform up glide to the left, down gliding to the right. Do it on both sides. How's it feel? getting better. And I'll show you the side planks.
And you can use a pillow as a wedge if you feel like you need a pillow between you two.
Okay. Yeah. So this is just working the core, all the stabilization muscles necessary for posture.
Which muscles are they work?
We work in all the core muscles, so it's a lot of abdominals. Actually working glutes. Working latissimus. Working a lot of muscles. You haven't want to add to just
upper, the rotator cuffs, we're working on back muscles as well. All right, for problem number 3, we have limitation reaching over the head due to reduced flexibility and extensibility. Posture correction exercise aim to stretch and strengthen the back and the abdominal muscles and kinetic chain, which help stabilize the spine. We're gonna do education and safety, postural training, and perform pelvic tilts on spine. For the moderate protection phase, we're gonna do some rotation stretch of the upper body on the quadruped position. And for the mid protection phase, it's when the patient returns to function, and we can do some quadruped exercise, alternate arm and leg, and we can add some weights to that. Or we can do the plank for 30 seconds for 5 times or 6. So for the max protection phase, I'm gonna have my patient in supine. We can do the plank. The knees are gonna be bent, and we're gonna do some posterior pelvic tilts. You're gonna push your pelvic up. There we go. We can perform this 3 sets of 10, hold it for 10 seconds, and then relax. Then for the moderate protection phase, we're gonna have the patient do some rotation of the upper body. I'm gonna have my patient on the quadruped position. We're gonna stretch the left arm under the body and stretch all over it. There you go. There you go. You can do the other one. We can do 5 sets of 5 seconds on each side. And then for our mid protection phase, we have the quadruped exercise, alternating arms and legs, like this picture right here. We can add weights to the wrist and to the ankle, and you can perform either 5 sets of 20-second holds or 10-second holds. Good. And those are our references.
I just have a question. Why did you all choose to do the side plank?
So personally, the side plank, it puts the spine in a different position. So your regular plank is gravity lessened at the cervical spine, but when you do the side plank, now it's causing you have to stabilize more because you're going against gravity, and that's why I chose the side plank for that particular.
What are the most common rehabilitation objectives that y'all try to fix with this dysfunction?
The primary objective is for the patient to go back with the mobility and function, and also we need to explain and educate the patient through the process. But the final goal is return the patient to mobility and function.
For posture, you guys did the tactile cueing, what is something else that you can do? Because you're not always going to be there with the patient, so what could you provide them for like if they're sitting in a chair for long periods of time or things like that?
Yeah. Verbal cue, so I would tell them, I would see how they react to that, and I would just tell them kind of if they're overly extended, I would tell them throughout the day, check your posture and try to bring your shoulders towards your chest a little bit. Typically, if they are that extended, if I tell them that, they're not going to overly flex. So I think giving them that verbal cue will give them enough.
Out of all the exercises that you know today, which one do you think would be the best for at-home exercise that you said one would do?
I think the posture education and how they fix it is the easiest one because you don't need any kind of equipment, or you can do it at work at home and you can be sitting down and helping straighten the back and having the posture and just working that without any kind of equipment. So I think that one is the best one.
How often would you tell them to like remind themselves to sit up straight, just like throughout the day?
Throughout the day. Well, I don't know you look for it on your side. Like how many, like on the public side, or
I didn't say anything specific about, how long to tell them, but typically, I guess it depends on what they're doing throughout the day. If they're doing something that's seated a lot, tell them maybe, every 15 to 30, just check your posture.
yeah, because it's really easy to just crouch or hyperextend just, working in office and stuff like that. You forget sometimes. We usually do.
Oh, so go ahead.
It's fine.
No, I didn't see your hand. Go ahead.
Sure.
Okay.
And one more question, let's see how you did the, down glide and up glide again.
I think what you asked. So, hands here. And if I'm down gliding to the right. This is my diagram, I'm trying to put it up. This is my down glide to the right.
So what are you doing? Explain that process.
So I am along her cervical spine. I'm not at this particular segment right now. Well, I am down gliding the entire cervical spine, and I am kind of pushing, providing an in-force here, and providing a upward force here, making the cervical processes glide downward.
Okay, so that's what I thought I heard. Okay, so correction. So you see her head? So now. So let me show you. So correction. So you want the plinth high enough so that the top superior aspect of her head is resting like right on your navel. So her head is resting on my navel, and I can let go like this. You see? That puts her in slight flexion. Now this hand right here, this hand is just gonna be placed. So if I'm doing down glides on the right side, this hand is just gonna be placed and it's just gonna be there. Okay? All right. I'm gonna assess the down glide on both sides. So I assess one side, then I'm gonna assess the other side at a particular segment. Okay? So you can start up at you can start at C2 on C3, or you can start a C7 on T1. I tend to work my way up. So right here, I have both hands, right? And now I'm gonna be applying my force in a diagonal manner towards her opposite hip on the right side. Notice her head is still in loose pack position because it's on my navel. All right, somebody may get this on the final practical. That's why I'm going over this. All right, so when I perform the down glide, I'm gonna assess it on the right side, C7 on T1. That's what she has right there. Then I'm gonna come back. So notice his hand didn't do anything. I didn't do this with this hand or nothing. And I'm not verbalizing that I'm performing an up glide on the opposite side. I'm staying away from that, all right? Because my only concern right now is to assess the down glide on the right side at C7 on T1. That's my primary focus. Now, after I have assessed the down glide of C7 on T1 on the right, my hand is already placed, my left hand is already placed so that I can assess the down glide of C7 on T1 on the left side, like so. You see? And what am I doing with my right hand? It's just there, all right? It's just there supporting, all right? So I'm not doing anything with it. I'm not doing an up glide on the right with that. I'm not concerned about the up glide on the right now, because I'm particularly assessing only the down glide of C7 on T1. I'm not assessing the down glide of the entire mid-cervical spine. I'm going segment by segment, okay? Now I can move my hand up some, just about a finger width with my index finger. And now I know that I'm assessing C6 on C7. I work my down glide to the right, see how far she can go, and I assess that infield, and that's it right there. Wouldn't you agree? As far as I can go. And I'm gonna compare this. My hand is already positioned on the left side. Now I'm gonna compare the left down glide. Now, much less. Would you agree? That's all I can get. So at C6, I can make a clinical impression right now and notate this while I'm assessing my patient. C6 on C7, considerable hypomobility in comparison to the down glide of C6 on C7 on the right side. So the left side is considerably hypomobile compared to the right side with the down glide of C6 on C7. So you want to do each segment like that. So that's why I had to stop you. I can't let that go. Can't let it go without correcting you, because somebody will come to the practical and think that's how you do it. So notice, her head is still resting on my navel. My hands are free. This helps put her in a loose pack position. Now I'm not aggressively applying a compressive force. I just got enough force to maintain her in flexion. So I'm not adding a compressive load. Does that make sense? I'm not adding a compression load, but just enough so that her head maintains a slightly flexed position. Does that make sense? So those are the down glides. So you're gonna assess the down glides on each side, working your way up segment by segment, or either working your way down. If you decide to go C2 on C3, C3 on C4, C4 on C5, C5 on C6, C6 on C7, C7 on T1. I mean, you can do that. So now, this is where we get confused. So the down glides, now this is a review. So the down glide assessment can be slightly different from the up glide. So with the up glide, so you notice with the down glide, alternated with assessing each side, right? So typically with the up glide, I assess all segments on one side first, then assess all those same segments on the other side. Now you can interchange if you want to, but you'll be constantly changing the patient. So typically, now Dr. McClure may approach a little bit different. It just all depends on, because some of these techniques we finesse, we learn them when we go through the courses with the clinicians who teach them. But once you become a skilled at it and you become experienced, you may finesse it and tweak it a little bit, you know, to your likings. So what I tend to do when I assess the up glide, I tend to rotate the patient just a little bit and kind of side bend them just a little bit to the right if I'm going to assess the up glide of the left. So I'm going to have her to maintain this position, and what I'm going to do, I'm just going to assess all of them, each segment, while the person's in this position, instead of keep changing positions. You see? So I can come right here, locate C7 on T1, and I perform an up glide. In a sense, this is what my hand is doing. This is what my index finger is doing. Okay. So I can set an up glide, a C7 on T1, and kind of work my way up. C6 on C6 on C7, C5 on C6, C4 on C5, and keep going accordingly. Then after I assess all of those, I get the patient kind of slightly rotate, slightly side bend to the opposite side, and then coming up underneath and assessing the other up glides, working my way up. Anything to add, Dr. McClure?
Not really. I think I did it pretty well the same way, except I'm gonna go top down.
Yep, so Dr. McClure goes top down, which I say you can go top down as well. It's just however you practice, you know.
Just be systematic.
Just be systematic, yeah. Thank you. You're welcome.